Hello, my name is Dr. Melissa Wright, and I'm a pediatric autoimmune neurologist. I'm going to be discussing multiple sclerosis in this presentation, which is a common condition in the field of neuroimmunology. In this presentation, we will discuss what multiple sclerosis is, the epidemiology of multiple sclerosis, the pathophysiology of the disease, clinical presentations, diagnosis, and treatment. Multiple sclerosis is an immune-mediated disease of the central nervous system, causing episodes of demyelination. Myelin protects and insulates the axons of a nerve, helping signals travel along nerve fibers to control the body. Demyelination is damage to and loss of myelin around the axons of a nerve. When demyelination occurs, these signals that go to different parts of the body are blocked or slowed. This results in various neurologic symptoms based on the areas of demyelination in the central nervous system. When this is left untreated, multiple sclerosis will result in ongoing episodes of demyelination, causing neurologic disability. The prevalence of multiple sclerosis in the adult population is about 350 per 100,000. MS is seen more frequently in females with a ratio of about 3 to 1. At the first presentation of MS, patients are typically a young adult age, usually between the ages of 20 and 40. However, multiple sclerosis can occur at any age, including in children and older adults. Approximately 10% of patients will have pediatric presentations of MS. We don't really know all the reasons why some patients get multiple sclerosis, but we do know that there are certain risk factors that seem to be associated with multiple sclerosis. This includes an EBV infection or prior EBV infection, obesity, smoking, low vitamin D levels, geographic location with a higher risk of multiple sclerosis in locations farther from the equator, and then also genetics. However, this is also, we know that this is a complicated interplay between genetics and environment. There is a higher risk of multiple sclerosis for patients who have, or for people who have a first-degree relative with multiple sclerosis, but in identical twin studies, we found that an identical twin has about a 1 in 4 risk of developing MS if their twin has been diagnosed with MS. This highlights the fact that there's an interplay between both genetics and environment, and that genetics alone don't explain the risk of developing multiple sclerosis. There's been a significant amount of research undertaken to understand the pathophysiology of multiple sclerosis. As I mentioned on the previous slide, this disease is a complex interplay and interaction between environment, genetics, and the immune system. In multiple sclerosis, there's an abnormal immune response resulting in inflammation. This leads to breakdown of the blood-brain barrier and allows inflammatory cells to enter into the central nervous system. As part of this, T cells, which are cells that are part of the immune system, become activated and trigger a complex inflammatory cascade, which can involve cytokines and other immune cells. In addition, T regulatory cells, which typically will turn off inflammation, are not functioning properly, and this causes ongoing inflammation, leading to more injury to the myelin. B cells are also activated, causing further damage. Further inflammatory responses can also occur as demyelination occurs. Following a period of active inflammation, axonal injury, neurodegeneration, and remyelination can occur. However, as part of this process, there is residual injury, which leads to the formation of what we often call MS plaques. These plaques can be seen as changes on both gross and microscopic pathology, and are also seen as permanent changes on MRIs. The symptoms of multiple sclerosis depend on where the demyelination occurs and how significant the damage is. Because it can involve any area of the central nervous system and disrupt critical sensory and motor signals that are sent out to the body, multiple symptoms affecting control of the body may occur. These symptoms may include fatigue, memory and cognitive difficulties, mood disorders such as depression and anxiety, double vision or loss of vision, weakness, including paralysis of one or multiple limbs, numbness and tingling, coordination difficulties, bowel and bladder dysfunction, walking and balance difficulties, vertigo, and tightness and cramping, or even spasms in muscles. The clinical presentation of MS, most patients don't present with all these symptoms that I discussed on the previous slide all at once, but may develop multiple symptoms with time. Multiple sclerosis typically follows one of three different types of pattern of clinical course. The first is relapse remitting, which is the most common presentation. In relapsing remitting MS, patients will develop acute episodes of neurologic symptoms, and these are known as relapses. In between these relapses, the symptoms remit, meaning that they improve, although recovery is often incomplete. With new relapses, new neurologic symptoms typically develop. In contrast, in primary progressive MS, patients do not have recovery in between neurologic symptoms and develop this gradually progressive neurologic dysfunction. In secondary progressive MS, patients initially follow a relapsing remitting course, but with time subsequently develop ongoing progressive neurologic dysfunction, similar to the pattern seen in primary progressive MS. The diagnosis of multiple sclerosis is made clinically with supportive information. There's not a single test that can be taken alone to diagnose multiple sclerosis. Rather, the diagnosis must be made based on assessment of the clinical presentation of the patient, imaging findings, as well as cerebrospinal fluid testing. MRIs of the central nervous system are essential to making the diagnosis because we can see the MS lesions or these plaques on imaging. These can be seen in the optic nerves, brain, and or the spinal cord, all areas that can have demyelination and are part of the central nervous system. These lesions typically have a characteristic pattern and appearance, which help us identify them as MS lesions. Additionally, more lesions may be seen than the patient has symptoms of. It's not uncommon for us to have MRI findings with multiple lesions, despite the patient only having one or mild symptoms. There may also be evidence of old lesions in addition to new lesions. To help us determine if lesions are newer and active in terms of active inflammation, we use gadolinium contrast, which is given to patients during the MR imaging. This helps determine if lesions are active, because in active lesions, there's disruption to the blood-brain barrier, and contrasted enhancement is seen in these lesions if active. CSF testing is commonly performed as part of the diagnostic process of multiple sclerosis. We will often see mild elevations of white blood cells in the spinal fluid indicative of inflammation. Additionally, we will often see oligoclonal bands. Oligoclonal bands are abnormal protein that's seen in the CSF and not in the serum that indicates central nervous system specific inflammation. Oligoclonal bands are seen in the majority of patients. Although they can be seen in other autoimmune neurologic conditions, 95% of adults with multiple sclerosis will have oligoclonal bands. So this can be a very helpful part of the diagnostic process. A diagnosis of MS requires a demonstration of two different things: dissemination in time and dissemination in space. Dissemination in time means that that patients demonstrate that they've had either both new and old lesions, or that they've had clinical symptoms that have followed a relapsing course, meaning that they've had clinical symptoms at multiple time points that correlate to lesions on their MRI. Additionally, dissemination in space indicates that there are multiple parts of the central nervous system involved and that lesions are seen in more than just one area. If patients don't meet criteria for dissemination in time, then we often follow them closely if we have concern that this will progress and patients will develop another episode that would meet the criteria for dissemination in time. Additionally, there's many mimics of multiple sclerosis. So if patients have atypical imaging or presentations, we think about these other conditions. In these images here, you can see the areas of the spinal cord and the brain that appear more white. These are the MS plaques that I was referring to previously and are characteristic lesions of multiple sclerosis. When we discuss treatment of multiple sclerosis, we think of three different things. First is treatment of acute relapses and how we manage those acute neurologic symptoms. We then think about disease-modifying therapy, and then we also think about symptomatic treatment. Acute relapses are new neurologic symptoms that last greater than 24 hours. With these new lesions or in these new neurologic symptoms, MRIs typically show contrast-enhancing lesions. As I mentioned previously, this indicates breakdown of the blood-brain barrier and active inflammation. The goal of acute treatment, when it's given, is to reduce this active inflammation. We know that treatment of acute relapses can shorten duration of symptoms for patients, potentially, but it doesn't really change the overall outcomes of patients. So when we have a patient who has an acute relapse, based on the severity of symptoms, we decide whether treatment is needed or not. We don't always treat relapses if symptoms are mild, as we know that, as I mentioned, this doesn't necessarily change overall clinical course or outcomes. The typical treatment for an acute relapse is IV steroids, which are typically given for 3 to 5 days. Recovery from these relapses is not always incomplete, but often is incomplete, or patients might have residual symptoms that they might notice if they're more tired, overheated, or fatigued. Lesions persist on imaging. As I mentioned, those plaques continue to persist, and we see those with subsequent imaging. The second thing we think about is disease-modifying therapy. After a patient is diagnosed with multiple sclerosis, we have discussions about which disease-modifying therapy to start a patient on. The goal of disease-modifying therapy is to stop and slow the progression of disease. Additionally, it's to prevent further relapses and thus prevent accrual of neurologic disability. This does not treat acute relapses, and it does not reverse prior damage. However, as I mentioned, the goal is to prevent further damage from occurring. So this is an essential part of treatment. We have over 24 FDA-approved medications for adults with multiple sclerosis. There has been a significant increase in recent years, and previously, years ago, we had very few treatments for multiple sclerosis. These medications come in various forms, including injections, oral medications, and infusions. They also may be immune modulatory or immunosuppressive. What we mean by immune modulatory is that the immune system is modulated in its function, which seems to reduce the risk of relapses, versus immunosuppressive medications, which actually suppress certain aspects of the immune system. These medications that are immunosuppressive seem to be more, or tend to be more efficacious in the treatment of multiple sclerosis, but they come with additional risks and side effects, given the fact that they are immunosuppressive. So when we discuss starting disease-modifying therapy with patients, we discuss with them that we have to balance efficacy of a medication with the risks involved. These treatment decisions are very individualized, and we approach each patient as a unique case in terms of how we decide which medication to start. This there are multiple factors that go into this, including age, the preferences of patients, risk of medications, side effect profiles, and the aggressiveness of multiple sclerosis. For example, if we have a patient who seems to have very mild lesion burden and really no neurologic dysfunction at the time of diagnosis, then we may opt to choose an immune modulatory medication with lower risks. However, if we have patients that have a high lesion burden or significant residual neurologic symptoms, we might discuss starting higher efficacy medication that will be immunosuppressing, but be more effective in controlling the multiple sclerosis likely. In this figure, in the yellow boxes, you can see that we have multiple different medications that work on multiple different parts of the immune system. The mechanisms of medication that we have for multiple sclerosis have various actions. They can regulate immune responses, trap immune cells in lymph nodes, prevent immune cells from entering the central nervous system, reduce the production of T cells, and reduce the reduction of B cells. The efficacy of disease-modifying therapy should be monitored closely. Of course, clinical relapses help us know if patients are, if a disease-modifying therapy is effective, if patients are not having clinical relapses. However, some patients will also have, or most patients will, with multiple sclerosis, will develop, if not adequately treated, develop lesions that they may not be symptomatic from. Because of this, we have to perform surveillance imaging on patients, oftentimes annually, to ensure that they're not having new lesions on their imaging. If patients have relapses or have new lesions on imaging while on a specific disease-modifying therapy, oftentimes we'll need to change to a higher efficacy medication. Additionally, as part of our treatment of multiple sclerosis, vitamin D supplementation is utilized as part of standard treatment, as we know that low vitamin D levels it confers a higher risk of demyelination and relapses. In addition, we also like to think about symptomatic management. These patients can have pretty significant neurologic symptoms that interfere with their day-to-day lives. Depending on the area of the central nervous system, these symptoms can be varied, and some of these symptoms can be treated with medications. Decreased stamina and limitations in walking, fatigue, spasticity and pain, bladder dysfunction, and depression and anxiety are all symptoms that we have medications for that we can help to improve the quality of life of patients. Additionally, some patients with significant disability will need ambulation aids, even wheelchairs and scooters to help get around, and adaptations for daily function. For example, patients who are weak in their lower extremities may benefit from adaptive changes to their cars to allow for hand controls so they can continue to drive and be independent. Additionally, healthy lifestyles, physical therapy, and exercise can help patients maintain the neurologic function that they have. Here are some additional references, and thank you for listening to this talk on multiple sclerosis.